Okay. Hello, everyone. Welcome. My name is Ryan Severja. I'm one of the chief residents of internal medicine at Jackson Memorial Hospital. It's my pleasure today to introduce our speakers for Grand Rounds. Our first speaker is Dr. Binu John. He's an associate professor of medicine at the University of Miami and the gastroenterology lead for VISN 8, as well as chief of gastroenterology and hepatology at the Miami VA Health System. He's a practicing gastroenterologist, hepatologist with a broad background in clinical outcomes and translational research. His research is focused on chronic liver diseases, including cirrhosis, portal hypertension, hepatocellular carcinoma, primary biliary cholangitis, and steatotic liver disease. He's a federally funded researcher and has over 110 peer-reviewed publications and 200 abstracts, including in high-impact journals such as Nature, JAMA Internal Medicine, the Journal of Gastroenterology, Gut, and the Journal of Hepatology. He also has an H index of 33. So please join me in welcoming Dr. John.
Good afternoon, everyone. Thank you for the kind introduction. Over the next few minutes, I want to give you an overview of all the hot topics that's happening in hepatology. It's been a very exciting 1 or 2 years in hepatology. I don't think we've had so many new advances in the field in at least the last 15 years. So after the advent of hepatitis C treatment, we've probably had the most exciting year or two. And so I'd like to share some of these with you. The first thing is I want to talk to you about a new name and definition for what we used to call NAFLD, or non-alcoholic fatty liver disease. It's now called MASLD, or metabolic dysfunction associated steatotic liver disease. And I'd like to introduce you to a concept of what we now call MET-ALD, which is MASLD with increased alcohol use. We'll discuss the first drug ever approved for MASH, which is after almost 20 years of failed clinical trials. We now have a drug approved for MASH, which is resmetirom, approved about a year ago. And most recently, about a month ago, we have the second drug approved for MASH, which is semaglutide, as you know, the GLP-1 receptor agonist. We'll discuss some data on GLP receptor agonists for treatment of alcohol use disorder, as well as MET-ALD, the steatotic liver disease from both metabolic dysfunction and alcohol. And then finally, we'll discuss some data on using liver stiffness measurement on FibroScans in patients with MASLD to target patients for liver cancer surveillance. So as I started, NAFLD is now MASLD. So non-alcoholic fatty liver disease is now metabolic dysfunction associated steatotic liver disease. And why is that important? Because it's more accurate. Non-alcoholic was based on a disease of what it's not alcohol, as opposed to MASLD, which is metabolic dysfunction. That's what's causing the disease. And two, it reduces the stigma. So the term non-alcohol, having alcohol in there, and the term fatty liver was, patients found that to have a lot of stigma to those disease. And so having MASLD, this was based on a Delphi consensus of leading experts around the world. And so now NAFLD is MASLD, and what we used to call NASH, or non-alcoholic steatohepatitis, is MASH, metabolic dysfunction associated steatohepatitis. So when you have a patient with steatotic liver disease or fatty infiltration in the liver, and you can find that in one of two ways, patients might present to you with abnormal liver tests. You do an ultrasound or a CT and you find fatty infiltration or steatosis. Or you might do an imaging for unrelated reasons. You might image the kidney and find steatosis. You have three main etiologies contributing to it. So one is MASLD, like we discussed, and two is alcohol. Alcohol is a very common cause of steatosis. And then three is the condition I spoke to you about, which is the dual etiology, alcohol and metabolic dysfunction, which is MET-ALD. How do you differentiate between the three? So MASLD is essentially if you have steatosis and you have metabolic risk factors, and if your alcohol daily consumption is less than 30 grams if you're a male or less than 20 grams if you're a female. So that translates to approximately 1.5 to 2 drinks a day, because one drink of alcohol is 14 grams of alcohol. Whether it's a 12-ounce beer, it's a 5-ounce glass of wine, or a 1.5-ounce shot of alcohol, it has about 14 grams. So if you have less than 30 and less than 20, that's MASLD. On the other hand, if the patient drinks more than 60 grams as a male or more than 50 grams as a female, that's alcohol-associated liver disease, regardless of whether they have metabolic risk factors. And then patients in between, which is between 30 and 60 grams as a male or 20 and 50 grams as a female, have met-ALD. And what are the cardiometabolic risk factors that are required to establish a diagnosis of MASLD? It's one of these five. And as you can see here, the criteria is the bar is very low. So if you have steatosis and a BMI of 25, so not a BMI of 30, not a BMI of 27, a BMI of 25, and even a level of 23 in Asians will get you that metabolic risk factor. Hypertension or a blood pressure greater than 130 over 85. Diabetes or a fasting blood sugar greater than 100. A triglyceride level of greater than 150 or a low HDL, less than 40 in males and less than 50 in females. And why is this important? Because MASLD is highly prevalent worldwide. This was a study published about a year ago, which shows that 30% of the world population have MASLD. That's 1 in 3. And certain parts of the world have very high prevalence. So for example, Middle East and North Africa, 36.5. And then very relevant to us, Latin America has 44.4%. Nearly 1 in 2 individuals from Latin America have MASLD. And so that's very relevant to patients in Miami. And when you have MASLD, when a patient is MASLD, they progress, about 1 in 3 have MASLD. Between 12 and 40% can progress on to MASH, or metabolic dysfunction associated steatohepatitis, which is inflammation associated with that steatotic liver. And if you have MASH, about 15 to 25% of those patients end up with cirrhosis. And many patients with cirrhosis can get liver cancer, and patients with MASH can directly have liver cancer even in the absence of steatosis. So what drives this progression? One is genetic factors. So we know that genes like PNPLA3, TM6, SF2, diet clearly, certain diets, high carb diets, gut microbiota. Diabetes is a very important risk factor for patients to progress from steatosis to MASH, from MASH to cirrhosis, and it's an independent risk factor for liver cancer in patients with cirrhosis, and then obesity and cardiovascular disease. And one of the key factors that influence prognosis in a patient with MASH is the degree of fibrosis in the liver. And fibrosis can progress from stage 0, which is no fibrosis at all, to stage 1, which is mild, 2, 3, we call bridging fibrosis, and stage 4 is cirrhosis. So as you can see here on the graph on your left, on your right, if patients have stage 0 fibrosis and stage 1, the likelihood of liver-related mortality is about the same. So stage 1 fibrosis does not increase your liver-related mortality. But as patients progress on to stage 2, stage 3, and stage 4, they have a 2.5, 6.6, and 11.3 higher fold of liver-related death. And the same trend you see with all-cause mortality, stage 0 fibrosis, and stage 1, there's no real increase. But as patients progress to stage 2, 3, and 4, there's a significant increase in all-cause mortality. And so the patient population we want to target are patients with MASH, as well as patients with fibrosis, what we call at-risk MASH, which is stage 2 and 3 fibrosis, and of course, patients with cirrhosis. So that brings us to the first drug that was approved by the FDA last year. This was a paper published in the New England Journal of Medicine a year ago. This is an interim analysis of an ongoing phase 3 multinational double-blind randomized control trial that looks at the efficacy and safety of this drug called resmetirom in adults with biopsy-confirmed MASH. And it's important to know that both drugs that are approved for MASH are approved based on interim analysis of preliminary endpoints. In other words, this approval is based on an improvement on a liver biopsy. The final approval of any drug in MASH will be contingent on long-term data showing improved liver-related mortality and all-cause mortality. So this drug is a very interesting mechanism. It's a thyroid hormone beta agonist, thyroid hormone receptor beta agonist. And it's interesting because MASH as a condition is characterized by intrahepatic hypothyroidism. So in the liver, the T4 is converted to T3 using these diiodinase, and T3 acts on this nuclear receptor called thyroid hormone receptor beta. Now you have THR alpha and beta. The alpha receptors are located in other parts like the heart, bone, etc. And THR beta is the only receptor is expressed in the liver. And so when T3 normally acts on the THR beta, and it does two things. One, it increases free fatty acid oxidation, which reduces the total amount of free fatty acid in the liver. And it also inhibits what we call de novo lipogenesis, which is formation of free fatty acid. And so by these two mechanisms, normally you have decreased production of fatty acids. So what resmetirom does is it is an agonist at the THR beta level, and it stimulates this receptor and increases the following transcription factors or blocks them, and therefore increases the free fatty oxidation and decreases de novo lipogenesis. So what's the data show? So like I mentioned earlier, the approval of this drug was based on primary endpoints based on liver biopsies. So for all liver biopsies, the FDA has two co-primary endpoints. One is an improvement in MASH, or the improvement or resolution in steatohepatitis. So the steatosis and inflammation has to resolve with no worsening of fibrosis. And the second endpoint is improvement in the fibrosis with no worsening of steatohepatitis. So you need both endpoints for a drug to meet FDA approval. And you can see here that compared to the placebo arm of 9.7%, patients in the blue bars, the 80 milligrams and the 100 milligram dose of resmetirom met the primary endpoint of MASH resolution with no worsening of fibrosis. And you can see here, the delta here is about 15%, which means a number needed to treat of about 6 to 7 patients. So you treat 7 patients, you get MASH resolution in 1. What about fibrosis improvement by 1 or greater stage? The placebo arm was 14%. The drug was about 24 to 25%, a delta of about 10% with a number needed to treat of about 10 patients. And so the drug, based on this drug, was approved by the FDA, and this is the safety signs. Overall, it's very well tolerated. Most common side effects are diarrhea, nausea, and as you can see here, severe serious adverse events is almost the same level as placebo. So the drug is now approved for patients with MASH. So how do we use these in patients in our clinic? So once you have a patient that's diagnosed with MASLD or MASH, typically we do a non-invasive assessment of the degree of disease fibrosis. So like I mentioned, this drug is approved for the treatment of F2 and F3 fibrosis, or what we call at-risk MASH. So if a patient has F0 or F1 fibrosis, that's too minimal. We do not treat those patients. We do lifestyle modifications, and then we reassess the fibrosis annually. If they have cirrhosis, again, there's no data in patients with cirrhosis. There's an ongoing trial that's going on, but that results are not out. And so right now with patients with cirrhosis, we do not use this drug. But if you have a F2 to F3 fibrosis at-risk MASH, you start lifestyle modifications and start resmetirom. We typically treat the patients for up to 12 months, and then we reassess. If there's an improvement, we continue the drug. If there's no improvement, then we reassess for another drug. And how do we identify the F2 to F3 fibrosis? It's essentially either through what we call a VCTE or a transient elastography or a fibroscan. Patients with a liver stiffness between 8 and 50 kilopascals is who we consider for treatment. If it's high, greater than 20, for example, the patient likely has cirrhosis, not a candidate. If it's low, less than 8, patient likely has no fibrosis, again, not a candidate for treatment. So then we've been using this drug for about a year, and about a month ago, we received the second approval for a drug for MASH. And this is a drug that all of you are familiar with. This is semaglutide. And this again was a New England Journal paper, a phase 3 drug of semaglutide and MASH. So why use GLP-1 receptor agonists? We've had plenty of data over the years to show that weight loss by any mechanism can improve MASH. So even patients with diet and exercise who lose about 5% body weight have been shown to have an improvement in histological findings on MASH. And then we've also had studies in patients who had bariatric surgery. Patients who had bariatric surgery lost 40, 50 pounds, significant resolution of MASH and improvement in fibrosis, even in patients with cirrhosis. And then we know there's a very strong association between MASH and diabetes and obesity, and therefore a drug that targets this also targets the risk factors for this condition. And we are very familiar with the mechanisms for MASH, how semaglutide works. One, of course, it acts on the islet cells. There is an increase incretin effect, there's decreased gastric emptying. And we know that even in patients with, there is a decrease in food intake, there's increased weight loss. But it's important to note that there are no GLP-1 receptors in the liver. So the entire mechanism of how this drug works is extrahepatic. So by weight loss, it's not directly by acting on the liver. We have new drugs coming out now, which also work on glucagon receptors, which act directly on the liver. But right now, just semaglutide, the mechanism is purely extrahepatic. So how did they do this trial? Patients were randomized 2:1 into semaglutide versus placebo. And patients were started at low dose and escalated to a maximum dose of 2.4 milligrams. So it's important to note that this is not the dose for diabetes, it's the higher dose for weight loss. And patients were treated for a total of 72 weeks. Again, this is the histological endpoint, so this is interim analysis. A long-term analysis is going on to look at liver-related outcomes, which will be reported at the end of 5 years. And so this is the data again. Similarly, the two same endpoints we saw before. The resolution of MASH, we was able to see in 62.9% of patients compared to 34% in placebo. That's a delta of about 30%, so number needed to treat of 3. An improvement in fibrosis was seen in 36.8% of patients on semaglutide compared to 22% on placebo, a delta of 14, or a number needed to treat of 7 patients. And 1 in 3, 32.7% achieved both endpoints compared to 16% in the placebo. As is common with any GLP-1 trial, significant weight loss, about 10% mean loss of body weight. Of course, this is at the higher dose of semaglutide. And adverse events were very typical of what we see with GLP-1 trials. So this is an important breakthrough. It shows clear efficacy in MASH resolution and fibrosis improvement. And we also saw weight loss and metabolic benefits. We also saw indirect benefits on the liver, improvement in liver enzymes, improvement in indirect markers of fibrosis. And the study is now ongoing for cirrhosis-free trials, survival and clinical endpoints. So since we are on the topic of GLP-1, and we now use this for patients with MASH, metabolic syndrome, let's talk a little bit about data looking at the same drug in patients with alcohol use disorder, both alcohol use disorder as well as alcohol-associated liver disease. So this is data from our group that looks at the association of GLP-1 receptor agonists with liver-related outcome and all-cause mortality in patients with harmful alcohol use. The background is that GLP-1 receptor agonist has been observed in many anecdotal reports to decrease craving for alcohol and other substances. Many patients report that on GLP-1s, they self-report decreased use of alcohol. And the potential mechanism is a central one where it acts on the central GLP-1 receptors associated with reward, namely ones located in the nucleus accumbens and the ventral tegmental area. And there's a lot of both animal and human data to back that up. And therefore, the hypothesis is that reduces the rewarding effects of alcohol by modulating GABA release. There was a paper that was published about 3 months ago. This was in JAMA Psychiatry. This was an NIH-funded single-center study, randomized trial of 48 patients, 24 randomized to semaglutide and 24 to placebo. Very short duration of treatment. So patients received only 8 weeks of treatment. And what they did were they gave half the patients semaglutide, half the patients received placebo. And at the end of the 8-week period, they were taken into a laboratory where they had free access to alcohol. And they were timed. They had 120 minutes. They wanted, and the volunteers or the patients were told they can have how much ever alcohol they choose to. And what they found was patients on the semaglutide arm had significant decrease in the amount of alcohol consumed. In addition, they also found that their breath alcohol levels were much lower. So semaglutide, 33 grams of alcohol in that 120 minutes compared to placebo, which is 57 grams of alcohol. And so this gave a proof of concept that the GLP-1 receptors decrease craving for alcohol and decrease alcohol use. So based on that, we looked at the national VA data and we matched 8,000, a little over 8,000 patients who received GLP-1 receptor agonists. And these are patients with harmful alcohol use as identified by an elevated AUDIT-C. And we matched those to 8,000 patients who received a placebo. And essentially we did what we call a target trial simulation. And our outcomes were actual outcomes of liver-related disease. So hepatic decompensation, liver cancer, and liver-related death. We also looked at all-cause mortality. Additionally, a subset of patients had follow-up Audit C. Audit C is a questionnaire that looks at alcohol intake and craving. And we also looked at the change in Audit C over time in patients who got semaglutide versus placebo. And you can see here in the graph, what here in red is the placebo, out here in the blue is semaglutide. There is a 30% reduction in liver-related mortality, or liver-related outcomes in patients on semaglutide. Overall mortality was even more significant, a 57% decrease in mortality in patients who received the GLP-1. And there was a dose-dependent relationship. So for every 1 milligram additional dose of semaglutide received by a patient, there was a 50% decrease in liver-related outcome. And then you can see here, this is the Audit C score that we looked at baseline and at follow-up. Both in males and females, there was a decrease in Audit C in patients on GLP-1 compared to placebo. So what this provides is it gives us a proof of concept that semaglutide use not only decreases liver-related outcomes, but also potentially reduces alcohol use in patients with harmful alcohol use and metabolic syndrome. And therefore, this sets us a stage for future trials in patients with MET-ALD, the metabolic dysfunction and alcohol-associated steatotic liver with GLP-1. So finally, we'll talk about looking at MASLD and risk of liver cancer outcomes and how we can predict that using liver stiffness measurement. Again, this was published from our team and recently published in Hepatology. So as a background, MASLD is now the leading cause of primary liver cancer in the United States and worldwide. And a substantial proportion of these patients develop liver cancer in the absence of cirrhosis. So when patients have cirrhosis, we identify them for surveillance and we do 6-monthly ultrasound to pick up liver cancer. But in patients without cirrhosis, there's no way, because 1 in 3 people worldwide have MASLD, and it's impossible to do surveillance in such a large population. So it's very crucial to identify tools to identify high-risk patients without cirrhosis and MASLD to target them for surveillance. And liver stiffness measurement, which we use a FibroScan or transient elastography, is a promising biomarker for liver cancer risk stratification. So we included over 30,000 patients with MASLD who underwent the liver stiffness measurement with a FibroScan in the national VA system. You can see that the majority of those patients, 22,000, had a liver stiffness less than 10, which is a low level. And about 1,800 patients had a stiffness that's greater than 25 kilopascals. And then you had patients in between. And so we stratified these patients to liver stiffness of less than 10, 10 to 15, 15 to 20, 20 to 25, and greater than 25. And then we looked at incident liver cancer rates in these patients. And here's what we found. In patients who had less than 10 liver stiffness, kilopascals liver stiffness, the rate of liver cancer was extremely low, less than 0.06% per year. As you go up to 10 to 15, it's 0.34, 0.45, 0.78, and then in those greater than 25, it's greater than 0.94. And with every 5 kilopascal increase in liver stiffness, there is an 18% increased risk of liver cancer. And you can see that here in the Cox proportional hazard model with the cumulative incidence frequency. This is the group with less than 5 kilopascals. As you go up to 10 to 15, 15 to 20, 20 to 25, and more than 25, there's a stepwise increase in liver cancer risk over time. And so that's all patients, cirrhotic and non-cirrhotic, but we already do surveillance for patients with cirrhosis. The goal here was in patients without cirrhosis, can we identify a group of patients who have a risk of liver cancer high enough that we can target for surveillance? And it's been estimated that if your annual risk of liver cancer is greater than 0.4% per year or 0.4 per 100% years, that's a population where liver cancer surveillance is cost effective. And as you can see here, there were 3 independent risk factors for patients. If you have a liver stiffness greater than 10 and diabetes, those were patients who had a liver cancer risk of greater than 0.4. And you can see that in multiple subgroup analysis. Liver stiffness greater than 10, males and diabetes. Again, risk is greater than 0.4. But anytime patients have no diabetes, so for example, here it's liver stiffness 10 to 15, age less than 60, no diabetes, you can see that your incidence is lower than 0.4 to the left of this line. And so what we found is in patients with non-cirrhotic MASLD, patients who have liver stiffness greater than 10 kilopascals and diabetes have a liver cancer risk that's above the threshold for cost-effective HCC surveillance. And so that's an important advance in the field because now we have a way to target patients with MASLD. Out of the billions of patients with MASLD, we can identify that subset of patients without cirrhosis who still have a risk that's high enough to require surveillance. And so to conclude, we mentioned how NAFLD is now MASLD, metabolic dysfunction-associated steatotic liver disease, characterized by steatosis, cardiometabolic risk factors, and alcohol intake less than 30 grams in males and 20 grams in females. We discussed this new category of MET-ALD characterized by metabolic dysfunction and alcohol causing steatosis. We discussed the data on the first FDA-approved drug called resmetirom that's now been around for a year, GLP-1 receptor agonist, and data on semaglutide, which is the second drug approved for MASH. It's now available. And then we discussed potential role of GLP-1 receptor agonists to treat both patients with alcohol use disorder and MET-ALD, but I'll have to caution that's preliminary data, and we need a lot more data to prove that in future randomized trials. And then finally, we discussed how we can use liver stiffness measurement on a transient elastography or FibroScan to predict liver cancer risk in non-cirrhotic MASLD. That might be a way to guide surveillance for patients without cirrhosis. Thank you, and I'm happy to take questions.
Thank you. Thank you, Dr. John. I'll be covering for Dr. Weiss, even though he's here today. I'll be covering for Dr. Weiss for the next few sessions. So thank you for that great talk and also for showing us the study design of a 2-hour open bar as part of the methodology from the JAMA Psychiatry article. First question, just you mentioned, obviously, like a lot of people ask with resmetirom, is it going to go out of business now that semaglutide got approved? Can you talk a little bit about what, if any, weight loss occurs with resmetirom, and if, and as a follow-up to that, do you see an opportunity? I think you mentioned it briefly in one bullet point, combination therapy, both intrahepatic and extrahepatic ability to export fat and improve disease.
Sure. So thank you. So it's important to note that when the resmetirom trial was done, the trial design did not preclude patients from being on semaglutide, but they had to be on a stable dose of semaglutide, and they had to be on it for longer than several weeks. And so about 1 in 3, nearly 1 in 3 patients on the resmetirom trial were actually already on semaglutide. So how do you position, now that we have 2 drugs approved, how do you position this? The way I think about it is, clearly the NNT, the number needed to treat, is much lower for semaglutide compared to resmetirom. And so, and plus you have all these extrahepatic benefits. You have weight loss, you have cardiac, long-term cardiac benefits. And so I'm thinking most likely that'll position GLP-1 receptors as the first line. But also important to note, there's no direct action of GLP-1 on the liver. And a lot of patients don't have improvement in hepatic fibrosis. And that might be a population of patients where you could apply resmetirom to try and get that improvement in liver stiffness.
Great, thank you. Any other questions? Okay, go on to the second presenter.
Here.
All right, our next speaker is Dr. Karmali. He's a clinical instructor in the Division of Pulmonary Critical Care and Sleep Medicine here at the University of Miami and Jackson Memorial Hospital. He completed medical school at Loyola University, Chicago Stritch School of Medicine, residency at University of Louisville, and his fellowship training in pulmonary and critical care medicine here at the University of Miami. He served as a postdoctoral research fellow focused on environmental health and sleep medicine. His research examines how air pollution, obstructive lung disease, and sleep-distorted breathing interact to influence cardiopulmonary outcomes. He also has ongoing projects both here in Miami and in Uganda. He's received funding from the NIH, including recently receiving the Ruth L. Kirstein National Research Service Award, and his broader academic mission is to develop sustainable, low-cost strategies to reduce the burden of respiratory disease in resource-limited settings Please welcome Dr. Karmali.
Thank you so much for that introduction. Today, I'm going to talk about the advanced therapies that have been brought into the COPD realm. And just to start with some of my disclosures, I am a sub-investigator for some of the ongoing clinical trials that we are conducting here at the University of Miami related to biologic therapy within asthma and COPD. And what I really want you to get from this talk is one, that asthma and COPD, we know that they're clinically distinct entities, but there are shareable traits, particularly when it comes to inflammatory pathways. And I want you to think about, we know a lot about the pathophysiology of asthma as it relates to eosinophilia and type 2 inflammation. But after learning that, how can we apply those concepts to the realm of COPD treatment? And so we'll start with just understanding the global burden of obstructive lung disease. COPD is the third leading cause of death globally, and it incurs quite a bit of healthcare cost when you think about exacerbations and hospitalizations related to this disease. We know that asthma tends to predominantly affect the younger population, whereas COPD tends to affect the older population. And when we look at the guideline definitions, it's been noted that both asthma and COPD are heterologous obstructive diseases, but they have shareable traits, particularly when it comes to the inflammatory airway. And if they coexist, then you're suspecting concurrent asthma, then you would go ahead and treat the asthma. So when you see the patient, they often will present with cough and dyspnea. But when you're thinking about asthma, you should understand that it's largely a large airway disease. Only in severe forms does it start to affect the small airway. The patient's going to present with wheezing, chest tightness, and when you look at their PFTs, they're going to have variable lung function over time. In contrast with COPD, it's going to affect more of the smaller airways, the lung parenchyma, the pulmonary vessels. They're going to have more complaints of sputum production, and their lung function is going to progressively decline over time. They're going to have more exacerbations and reduced quality of life. Histopathologically, there are some distinct entities here. So on the left, you can see asthma. You can see a preserved alveolar architecture. There's inflammation, and usually we think of inflammation in asthma as eosinophils. A thickened basement membrane. The airway smooth muscle is hypertrophied, and you don't see as much fibrotic tissue, there might be a little bit there. In contrast, when you look at severe COPDers, the alveolar architecture is completely disrupted. You see more fibrosis compared to asthma. The basement membrane isn't as thickened. The airway smooth muscle may also be a little bit hypertrophied. And the inflammation that we generally see, we generally think is neutrophilic or macrophages. So I want to talk about, what have we actually come about with asthma and then before we think about COPD. So with asthma, there was a paradigm shift in thinking around 2010. So before, we thought a lot about asthma as let's control the symptom, let's control the disease as best as we can. But by 2010, we started thinking more about prevention. What are the biomarkers that are predictive of exacerbations? And how can we utilize that to an individualized strategy to control and prevent? And so that's where phenotyping became the biggest deal with this disease. So in asthma, we have found that the blood eosinophil count and the fractional excretion of nitric oxide are two markers that are predictive of worsening disease in asthma. And it's been integrated into the guidelines such that based on certain cutoffs and whether the patient's already on an ICS or an inhaled corticosteroid or not, will help guide the therapy of whether they need to have dose adjustments or if they need to be started on a biologic. And the reason why is because these are the surrogates for type 2 inflammation. And with having either or both of these markers poses a greater exacerbation risk in a person with eosinophilic asthma. Of course, you want to still integrate this with existing history, their exacerbation history, their symptoms, their lung function, et cetera. And so when you look at the GINA guidelines, there's actually a specific step where you assess their phenotype. And based on that phenotype, you decide if they have a propensity for a type 2 airway inflammation. And that helps guide your next steps for dose adjusting in ICS, considering other type 2 inflammatory diseases, or if biologic therapy is needed. So we took that concept of phenotyping and applied it to COPD. So here you can see that of a population of COPD patients with COPD, they found that there are about 4 different endotypes. The numbers vary, but up to 40% of cases of COPD actually have an eosinophilic subtype. And using the same concept of biomarkers, they found that the blood eosinophil count predicts COPD exacerbation risk and has a clinical response to inhaled corticosteroids. So here on the left, you can see between 2 treatment arms, the purple being the budesonide formoterol combination compared to just the formoterol. By having the inhaled corticosteroid, there's a reduction in exacerbation rate. And on the right, you can see that that exacerbation rate ratio drops right around the 300 eosinophil mark. So if you guys are familiar with some of the guidelines, 300 comes up fairly often. This is where that comes from. And so when we found that out, then we started looking at the Th2 inflammatory pathway. And so here's a diagram that shows basically your insult, whether it's the allergen or the virus, the downstream effect of activating the Th2 cell, and then the release of interleukins, so 4, 5, 9, and 13. And this is where eosinophils get recruited and activated. So 4 and 13 are actually responsible up here at the epithelial and basement membrane level, and it's responsible for airway remodeling, fibrosis, goblet cell metaplasia, and things like that. IL-5 directly acts on the IL-5R alpha receptor on the eosinophil and activates it. And the 9 is activating the mast cell. So this is when clinical trials started to look at this pathway and apply the same biologic therapies for asthma to COPD. So they started with mepolizumab. These are 2 phase 3 trials that were conducted, and they found that there was an 18 to 20% reduction in exacerbations compared to the placebo, but it was non-significant. They did the same thing with benralizumab. It's an IL-5 receptor antagonist. Same thing, a moderate reduction in exacerbations, but it was non-significant. The only success, one of the only successes we had was dupilumab. So this is IL-4 and 13 with the Boreas and Notice trial. So they found a significant reduction in exacerbations and improvement in lung function and improvement in quality of life within these patients. So why the mixed results? And that's because COPD is much more complex than just the eosinophilia. There's a heterogeneity of inflammation, not just with type 2, but with type 1, right? We predominantly think of the neutrophil and the macrophage within these populations. And there's a number of other inflammatory pathways that haven't really been talked about. And so this tells us a couple of things. One, it's not enough to just target a certain part of the inflammatory pathway, but the patient phenotyping is important, because the reason why dupilumab may have been successful was because it's targeting areas where there is airway remodeling on top of the eosinophilia. So what we'll see is in the Boreas trial, their patient selection were patients with eosinophilic COPD. They were already on triple inhaler therapy. They already had a blood eosinophil count greater than 300. And you can see reduction in exacerbation events on the left, and on the right, improvement in lung function.
Yeah.
He like
The guy with the.
two patients on X.
Okay. And then in the NOTICE trial, the same thing, reduction using the same cohort, reduction in exacerbation events, and even the time to exacerbation was longer with the intervention. And then as of May 2025, with the MATINEE trial, mepolizumab proved to reduce exacerbations. Now remember, this is IL-5 and targeting. And so again, it's the eosinophilic COPD on triple inhaler therapy with the blood eosinophil count greater than 300. So it's a very specific COPD population that's getting targeted with these biologics. And then coming back to some of these other trials that are currently ongoing, these are actually looking at either more upstream pathways of the Th2 inflammatory pathway, or they're looking at virally driven inflammatory pathways that occur. With the idea is that we have to be broader about thinking about these the patients when treating with biologics. So these are ongoing right now. So the EOS, it's not enough to just say the patient has eosinophilia. There's actually a lot of nuance to this and considerations. The first is that not all eosinophils are the same. There are two types of eosinophils, the resident and inflammatory. In this particular study, they compared eosinophils between an asthma group and a COPD match group. And what you can see is that the COPD group had more, significantly more resident eosinophils, which is more aligned with tissue repair, compared to inflammatory eosinophils found in asthma, which has more tissue destruction and it has to be recruited into the site of insult. And if you look at microscopy, it becomes even more evident that there are differences in the eosinophils. So cyclic 8 is just a marker for eosinophils, so it's lit up in all subgroups here. CD62 ligand, it's a ligand that's part of the recruitment. So if it's being bound to a receptor, as it is in asthma, as well as the asthma inflammatory eosinophil, that means the eosinophil is being recruited, actively recruited. And then CD125 is an IL-5 receptor, which you can see is very much bright in the asthma inflammatory eosinophil group. We've been using the blood eosinophil count as the marker for, as a threshold for starting a biologic, but really that's a matter of accessibility, right? It's actually the sputum and even more so the BAL eosinophilia that is more telling of whether the patient's gonna have an eosinophil COPD. And so that suffices to say that you can draw the blood and see the blood count, but it's not gonna be consistent necessarily. There's a lot of confounders with eosinophilia. So steroids can, in a population where they're constantly getting oral steroids, it's gonna suppress eosinophilia. And so you have to be cognizant, particularly when it's severe patients with severe COPD who are gonna be on these oral steroids. And then other things to consider is whether they have intrinsic or extrinsic eosinophilic disorders, if they have drugs associated with eosinophilia, or if they have parasitic infections that can cause eosinophilia. Okay, so going into the guidelines, so when you're thinking about asthma, you're gonna wanna start with an inhaled corticosteroid. But when you're thinking about COPD, you're gonna start with either a LAMA or a LABA, and then add the inhaled corticosteroid based on their clinical history. So if they're having frequent exacerbations, hospitalizations, or if they have the blood eosinophil count greater than 300. And you'll see there's a lot of red that talks about whether or not to add the ICS. And the reason is because low dose of ICS has the maximum clinical effect. But when you start to get to medium and high doses, you actually start to get similar adverse effects as if a person is having oral corticosteroids. So stewardship of the ICS has become very much a factor in the COPD guidelines and asthma guidelines. So in asthma, you can see that after you phenotype the patient and there's refractory to the treatment, then you can think about biologic therapy and use those markers of the blood eosinophil count, the pheno, as well as symptoms and other potentially other aspects of Th2 pathway diseases to decide what biologic to start. In COPD, if they're presenting with just dyspnea and you start them with just a LABA or a LAMA, then you can consider dual therapy, but also consider other aspects of dyspnea. Are they having a coexisting disease that can worsen their dyspnea? Do they need to be in pulmonary rehab, or even as simple as does the formulation aerosol versus powder, like does that matter for the patient? If they're exacerbating, then you can consider dual therapy, but you can see here in the pathway, the eosinophil count becomes very crucial in determining whether they should be started on triple inhaler therapy, or if you can skip to, using roflumilast or azithromycin, et cetera. If they're already on a combination with an ICS, then again, taking into account their exacerbation history, their eosinophil count, can help you de-escalate or to just a LABA or a LAMA, or consider triple inhaler therapy. So I just want to put in a plug about where we are in the state of Florida, what's going on with biologics. This is actually more representative of asthma, and you can see that there's still a high burden of uncontrolled asthma within the state of Florida alone. Over 54% of patients are still on systemic corticosteroids greater than 500 milligrams. Only 11% of biologics are being utilized within the state. And we actually were able to look specifically at the University of Miami and Jack's Memorial, and kind of similar numbers. We don't hit the national average for biologic use, and a lot of patients are still on systemic corticosteroids with high level of exposure. And so just suffice it to say that we, as a pulmonary division, have an established asthma and COPD program that are actively trying to enroll patients in some of these clinical trials and trying to get increased access to biologic care for these patients. So if you find this type of patient in your clinic, please refer them to us. With that, I'd like to thank you for your time, and I can take any questions.
Thank you very much for that great talk. We'll open it up for questions. I can just start by asking, the trials, the last few slides you showed about biologics, this disease, maybe unlike some other diseases, there's a lot of people that don't see pulmonologists, right, that are at their primary care. So were you able to break that down in terms of how likely you are to prescribe a biologic if it was a pulmonary clinic versus a non-pulmonary clinic?
Yeah, I think when you're at the step of considering a biologic, it probably should be in the hands of a specialist, because there are, adverse effects that need to be monitored, and these are patients that just need closer monitoring in general. I think it'd be difficult for just a primary care to consider. Whether those numbers have been broken down on a primary care level or not, that I'm not sure. But yeah, if you're at the stage where the person has very severe disease and you're considering a biologic, that's probably past the time when you need to refer to pulmonology.
Certainly so. Do you get a sense of like what percentage of people that have severe disease are seen in or get to you guys? Are they just kind of like,
I think it's a very low percentage.
that may contribute to some of these low numbers?
Yeah.
Other questions? Dr. Contreras?
Yeah, so
Just
the
repeat the
question is about the effect of infections and COPD exacerbations. And so that's where those ongoing trials are happening. They're looking, those are specifically looking at virally induced inflammatory pathways and seeing if those biologic therapies might help alleviate some of those exacerbations. So more to come.
Other questions? Anything from the chat, Laura? Yeah, that was for the previous one. I think there was a question about both drugs. I think Dr. John addressed that one. Any questions? Any other questions? Okay, thank you very much.